Hey guys, my name is Jordan. Today I'm going to be talking a little bit about acute renal failure or acute kidney injury. So, the chief complaint is that the patient is complaining of fever, nausea, vomiting, diarrhea for 48 hours, weakness, dizziness, and a metallic taste in the mouth. The history of present illness is this patient is a 73-year-old man who 2 days ago began to experience nausea and vomiting a few hours after eating fast food. The patient began to feel achy and warm and then had a temperature of 100.5. He continued to experience nausea, vomiting, and a fever, and the patient is unable to tolerate solid foods or liquids. Yesterday, the patient had 5 to 6 watery bowel movements and has been experiencing some weakness and dizziness upon standing. A little bit more about AKI. This is when the kidneys are suddenly no longer able to filter out waste products from the blood, and it is acute, so it occurs anywhere from 48 hours up to 7 days. This can occur in response to any underlying health condition, any emergent condition that places stress on the body, or even some medications. And if this is untreated, it can lead to chronic kidney disease. Some symptoms that you might see are nausea, vomiting, oliguria, edema, fatigue, shortness of breath, confusion, flank pain, decreased appetite, and high blood pressure. Incidence of AKI has increased from 61 to 288 per 100,000 patients over the last 15 years. With that being said, mortality has decreased from 40.4% to 20.3% per that same patient population. And it is known that the incidence of AKI does increase with age. So a little bit more about the pathophys. This disease process is either considered to be pre-renal, renal, or post-renal. That results in a decrease in renal blood flow and a decrease in glomerular filtration rate. AKI oftentimes results from acute tubular necrosis, and most of the time this is because of ischemia or nephrotoxicity, but AKI can also occur from glomerular damage, interstitial damage, and vascular damage as well, or a combination of the three. So there are phases that occur in AKI: initiation, extension, maintenance, and recovery. The initiation phase, you see injury to the renal tubular epithelial cells and also some renal ischemia. And then these renal tubular epithelial cells, as well as renal vascular endothelial cells, struggle to maintain normal renal function. And you see an increase in chemokines and cytokines in the beginning of that inflammatory response. And I also want to mention that you see some sublethal tubular damage, and this causes an impaired sodium reabsorption. And this is what activates tubular and glomerular feedback. And this increases afferent vascular resistance and ultimately decreases that GFR. Then you have the extension phase. This is continued hypoxia, and this is really where you see that inflammatory response come into play. Cellular necrosis and apoptosis are occurring mostly in the outer medulla, and the GFR continues to decrease, and you see that worsening of the inflammatory cascade. The maintenance phase is essentially just cellular repair, migration, apoptosis, and proliferation, where the body is just trying to reestablish homeostasis. And the recovery phase is when you see the polarity of these epithelial cells is reestablished. A little bit more about this specific case study. We see albuminemia, so that high level of albumin in the urine, and the kidneys work to not allow albumin to enter urine from the bloodstream. But because the kidneys have a low GFR and they are not filtering properly, that's when you start to see things like albumin and protein in the urine. And that next lab that we see is high protein, so that fits in there. And high bilirubin, this AKI can cause an increase in liver vascular permeability, which is why you can see that sometimes. A decreased GFR, we talked about how this is a key component of this and results in poor filtration. Increased creatinine Creatinine is a chemical waste product, and like I said, the kidneys are really no longer filtering properly, and so creatinine is just slowly building up in the body and not being excreted properly. You can also see an increased BUN. Some physical exam findings are sluggish pupil reaction, pale mucous membranes, weakness and dizziness upon standing, slight jaundiced appearance, and edema of the lower extremities. And the Christian worldview, Colossians 3:23 through 24, this is such a simple verse, but talks about working for the glory of the Lord and not just for yourself or not just for man. And in order to do this, you have to treat the patient holistically, and that starts just with therapeutic listening, and taking the time to not put them in a box, but really hear what symptoms that they've been struggling with, and really completing that thorough assessment. A lot of times, doctors get paid by the patient, and so it's really important just to take time to be thorough for their sake. And working for the Lord now for us means working to have a thorough understanding of the pathophys of AKI and other renal complications so that we can be better prepared to treat our patients in the future. And then obviously just having gentle and compassionate communication when you're giving someone some scary news that one of their vital organs is, suddenly not functioning like it used to. So some of the case study questions that I have, what is an example of a pre-renal cause of AKI? Is there a correlation between a decreased GFR and organ function? And then in these types of patients, what type of IV solution could be administered to keep the patient euvolemic? And these are some of my references. And that's about all I got. So thank you guys for listening.